fourth event in our Access program. Thank you all for coming. I think you're going to be really pleased with today's presentation. Just a couple of housekeeping things. If you have anything that whirs, whistles, sings strange music, or loud noises, would you please either turn it off or turn it to stun? Thank you. Or something, yeah. We'll get right into it because I don't want to take this man's time away from him. This is Jim Monahan. Jim is, let's see, Vice President of Education and Community Engagement for Community Hospice and Palliative Care. And for those who aren't familiar with that organization, the headquarters is right up the road on Sunbeam Road. They also have facilities in, what, 15 counties? 16 counties. I don't know where to start here. Jim sent me just a few little facts about him. He has more than 25 years of hospice experience in all different phases of hospice care. He's actually recognized internationally. He is a consultant to the Chinese Association for Life Care in Beijing. He tells me that very soon after this presentation, he's going to Barbados to give a talk and work. I offered to carry his baggage, but he said no. With him is Marie Reich, who is the Community Relations Representative for St. Johns County, and she has been an enormous help to us in getting things going. And finally, a little commercial for this program. When we started, we created a focus group of people, had them come in, we presented the concepts to them, and we got good thoughts and advice about what to do and how to do it. We're going to reconvene a focus group. It's actually going to come next month. And we have the members, but I could use maybe 2 or 3 more people. But they have to be people who've actually gone through this and know what it's about. So if anybody's interested, maybe after the session, maybe the first 2 or 3 folks who would want to join the focus group are more than welcome. Having said all that,
if they're interested, speak to me.
If you're interested, speak to Dwight Bailey.
Focus group.
Focus group.
Yeah.
Dwight Bailey. There it is. So, having taken care of all of that, I'm going to turn it over to Jim Monahan, and he has a good show for you.
Thank you, Dan. Thank you for being here today. This is a great crowd. Hopefully I can live up to your expectations, and I had a good build-up here. As Dan said, I've been doing hospice work almost 30 years. I started as a volunteer in Houston, Texas, and when I finished my master's degree in educational psychology counseling, I went on staff and started to work with patients and families providing support, and did that for a few years. Then I got into bereavement support. I'll talk a little bit later that hospices provide bereavement support after the death for families and other loved ones, and I did that for a number of years. Then got into administration from there. And at community hospice, I work with our bereavement department, community outreach. We have a large effort now going on with African American churches. I coordinate that, and a few other departments. We have Honoring Choices Florida, our advanced care planning program, and I work with that department too. So do quite a few things. It's one of the most fun jobs. Does it sound funny? I have a fun job in hospice. It's one that I've enjoyed the most. So I'm going to talk about hospice in general and community hospice in particular. And I encourage and welcome questions throughout. I'm not going to say hold your questions till the end. Let's make this a conversation. I know this is a really strong community with a sense of community. And I really thank you for welcoming me in. And I don't want to say to you, wait till the end to speak. Yes, sir.
Oh, no.
Oh, okay. Oh, we had a first question.
It's okay. Oh, okay.
Okay, we sound good. Okay. I was going to say that was fast. Good. So we're going to talk about hospice. Who, when, what, how much, and why. Those are the questions we'll answer. If there's anything else, we'll address that too. I usually like to get the difficult things out of the way first, so you're not sitting there thinking, I wonder who's appropriate for hospice and when and how much does it cost. But hospice is for people We provide services for people with a 6-month prognosis. And what that means, and Medicare writes this rule, and we follow it for non-Medicare patients as well. Initially, 2 physicians say that if the disease progresses along the course it seems to be, the person probably won't be with us in 6 months or less. It's a real difficult thing, and to me, that's the most difficult part of hospice, because the patients and families don't pay for it, but there's a large cost, and that's to acknowledge that statement that I just made. Now, because there's nobody on this earth who knows how long anybody has, just reminds me of my first patient ever. Let me just a little diversion here. When I started volunteering 29 years ago, my first patient was in his mid-20s. Young guy with cancer, he had a tumor behind his eye. I'd go visit him weekly and sit and listen to him. I remember one time saying to him, I was leaving the house after the visit, I said, "Sam, I'll see you next week." And all of a sudden, some little voice in my head said, "He's a hospice patient, maybe not." And Sam lay there, and I still remember almost 30 years later, he looked at me, he says, "You think you're so smart, don't you?" He says, "You think you're visiting me, but you could get hit by a truck on the way home and go before I do." So, one of my first hospice teachers was Sam, the first patient. And it taught me a big lesson then that every day with hospice I learned, none of us know how long we have. So live life, say goodbye, say I love you, and mean it. Every single day. But anyway, somebody comes on hospice service, and do the math with me, this is Medicare math. 90 days later, the hospice team with our physician, remember 2 physicians initially say, usually the referring physician and then the hospice physician. But 90 days later, our hospice physician and team reassesses, and we stay still 6 months or less. 90 days later, still 6 months or less than every 60 days. So 6 months is not a magic number. Patients stay on a lot longer. Sometimes patients are on a lot shorter. They say, I'm going to go try this treatment, I'm going to try this cure, want to do something else. So it's not a magic number, it's just a Medicare number that we work with. Okay. And it's usually when curative treatment has become futile, because the other cost of hospice is that Medicare won't pay for curative treatment and hospice treatment. And hospice treatment there's a word going around in the last few years, palliative treatment. Hospice care and palliative care are really the same thing. Palliative care is aggressively treating symptoms, not just pain, but nausea, vomiting, weakness, whatever else it might be. So everything we do is geared towards really 2 things, controlling symptoms and quality of life. If a person's receiving home health services from a home health agency, they have to be bedbound. We like our patients to be up and out, and we do all that we can. Sometimes we arrange trips. I remember a number of years ago back in Houston, there was a younger guy in his 30s on our service, and he was a UPS driver, so they're strong and fast and throwing boxes, gently, nicely throwing boxes, but moving boxes. And he was home and with his wife, and he was on our service. And the hospice I was with then arranged with this church to take care of the kids for the weekend. And we got them tickets to go down to Mexico and sit on the beach like they used to do. And that was hospice care. We don't send everybody to Mexico, but that was the special thing. We got it done. So the futile treatment. Now, if a person says, there's a cure, there's something I want to try, and it's curative, they can go off hospice that very day, hospice service, and then try that, and hopefully it'll work. And if it doesn't, come back anytime. We don't lose hospice benefits. And then we focus on quality of life for the person and the family with the illness. Hospice care, I kind of look at almost like a target. Patients in the middle, the sick person, family is around them, and everybody here will be considered somebody's family. It's up to the person who's the designated hospice patient who they want. And we help the family take care of that person. Our goal is to keep people at home. And then hospice staff is around them. Okay, so it's sort of concentric circles. And then I think the important thing to know is that hospice neither hastens nor postpones death. There's rumors out there that people go into our hospice houses and we do something. We don't. We've never, in my 30 years, I've never seen anything like that happen. Now we also, this is going to sound strange maybe, but people can have CPR if they're on hospice service. There's a federal law that for Medicare recipients that you do not have to have a DNR, do not resuscitate order, to receive hospice care. Problem is, you know, if we're out in the pool and we start to drown, CPR is probably appropriate. But if it's end stage, whatever the disease is, it's probably not going to bring somebody back to a quality of life. And the older we get, and I'm getting, you know, that part myself, bones are more brittle. And sometimes when people are doing CPR, it does more harm to the bones than anything else. So that's one of the rumors, that you need a DNR, but you don't. So, any questions so far? The history of hospice in general, the root comes from the word for hospitality, hotel, home. It's a Latin word. And in 1967, not too long ago, the first hospice program was established in London, England, by Cicely Saunders, who was a social worker, then became a nurse, then became a physician. So she's almost a hospice team herself, taking care of patients as they were facing the end of life. And she said, we need a much more humane way to do this. You know, even still in our healthcare system, death is seen as a failure or the enemy to a lot of people. But she said, it happens to all of us. Let's see what we can do to work with it and respect and honor people as they're going towards it. In 1974, the first hospice was started in Connecticut in the United States. There was a grant, I think it was National Institute of Health, said, let's see if this will work here. Then in 1979, not too long thereafter, Community Hospice was founded in this Jacksonville area. Then way later on, in 1986, Medicare included the Medicare hospice benefit. So before that, hospice was all volunteer services. There were volunteer nurses, doctors, social workers, volunteers, chaplains. Everybody was a volunteer and nobody was paid for it. But now Medicare covers it at 100%. There's no copay, no deductible, nothing along the way. And I'll explain what it covers
May
too.
I ask something?
Yes.
But you just said a while ago then that it could go for another 90 and
Mhm.
another 90.
Right.
Will Medicare continue that
Yes.
also?
Medicare will continue to cover it as long as we can show two things, that the patient still is showing some sort of a decline, and we do that with our medical records, or the patient's maintaining with the support that they're receiving. As long as we can do that, Medicare continues to pay. And if we can't show that, it's kind of good news, except there's, you know, a lot of people, once they're on hospice, don't want to get off because they have people coming to the house, bringing medicines, supplies, just sitting and listening. But sometimes if it seems like people are getting better, it's kind of a loss to lose the hospice staff. But we're required, and we would do it anyway, to find other people like home health or private duty or other services to come out there. So we don't just stop because we can't show decline. Good question. Our mission at Community Hospice is to improve the quality of life for patients and families and to be the compassionate guide for end-of-life care in our community. And that's what I see we are. We're expert guides. You know, we want to listen to you. What's important to you? What are your values? What's within your culture, your religious beliefs? Let us work with that. We're not coming in as the experts telling you how to do this, but hopefully we're listening very closely to what's important and answering questions and asking you questions too. Full disclosure, there's 4 hospices serving this area. We're the original hospice here, community-based, which means that our home office is here and we're not-for-profit. We have taken care of nearly 200,000 patients in our history, and I should update that. Last month we turned 40 years old. That's a lot of people. You know, and a lot of people think that hospice is a building. You know, we have about 1,250 patients on our service today. You know, I remember about a year and a half ago, I told my mother how large it was. Mom, I said, we have about 1,200 patients. She said, how big is the building? You know? But, you know, our goal is to keep people out of our buildings. We have, I think it's 8 care centers around. We work in the hospitals, we work in assisted livings, but our goal is to keep people where they want to be, and that's usually at home. You know, so that's why we come to the house, we keep people there. In our care centers, if you've not seen one, I have some pictures I'll show you, and if you ever want to visit, we'd love to show them around. They're very nice. If you have a negative view of it before you saw it, come and visit one. They're like nicer than a Hilton, let's put it that way. But our goal is to keep people at home, and if symptoms can't be controlled where they are, we can move somebody to a care center. That's where we have nurses, social workers, chaplains, physicians, all around the clock with the pharmacy there, so we can get the right medications in place. And the goal is to move the person back to where they were. You know, it's short term, just like going into the hospital. And I'll talk a bit more about that. Anything else there? We have about 900 employees and about 1,000 volunteers. I know some of the volunteers are in this very room. Yes, ma'am.
You're giving these numbers, is this locally you're talking
Yes.
about or nationwide?
No, this is our community hospice covering 16 counties. 5 counties right here, and about a year and a half ago, the state awarded us 11 more. So that's just community hospice, local. And then all of the money that we collect and receive stays here. You know, other hospices have home office in Miami or Toledo. We're here. Okay. Some people think hospice is only for very old people with cancer, and those two things are not true. We work with anybody of any age and any disease. You know, Alzheimer's, ALS, cancer, complications of AIDS, dementia, heart, really any disease, as long as we can show that the hospice prognosis, we can come in and provide support. Kind of looks like they're sitting out in your yard here, doesn't it? The picture. And then here's where we are. Just gonna, yeah. The original service area was over to the right, and as I said, about a year and a half ago, the state of Florida, AHCA, Agency for Healthcare Administration, awarded us 11 more counties, which is rare that a hospice is given more. But we applied for it, and probably 20 or 21 hospices did, and the state said, community, you're doing a good job, go out there. So now, tomorrow I'm going to be in Gainesville, where we have an office now in Lake City, and Palatka, and Gainesville will be opening soon. And we're hiring staff there, and they take care of people there. You know, we try to have people care for people in their neighborhood, you know, so they're close by. So to receive hospice care, people have to be living in these 16 counties. That's a licensure requirement. If they don't, another hospice will certainly serve them. Life limited expectancy, and then the physician originally has to write the order for it, and then the patient and the family agree. I mean, those are what Medicare requires, and that's just what we do. So what we have is comprehensive care to address the physical, emotional, social, spiritual needs, issues. We look at each patient as very different. There's not a cookie cutter. There's a plan of care that's developed for everybody when they come on service. And usually we sit down with the patient or the family and others to say what's important. The nurse will say, I'll be here twice a week, once a week, 3 times a week. The nurse's aide will come out if they need. Social worker, chaplain, volunteers. Maybe we don't decide that all on the first day because it could be overwhelming, but we decide and come up with the plan of care with the patient and the family. And then if we say, 2 nurse visits a week, we'll say and PRN, which means as needed. Because the rules and regulations are so tight, this is going to sound strange, that if we say 2 nurse visits a week, and if we go out 3 or 4 times because the people need us, if we get surveyed by the state, they're going to say you're not following your plan of care. And we'll get a deficiency from the state. Yeah. That's why when you read, sometimes I read, you probably don't because you don't have this strange interest like I do, like nursing home reviews online when the state comes in, I take it with a grain of salt because not every deficiency that somebody receives is negative. Sometimes doing too much, you get a deficiency, they call it, or a bad mark. So we provide care for the family and the caregivers there, not just the blood family, but anybody. If a person has private duty nursing aides coming in, we support them too, and we educate and train them. And we have to know that they're involved, and they know that we're involved, and we work together that way. And we are interdisciplinary. It's not just medical. That the person has a right to say, I have my own pastor, minister, rabbi, monk, whatever, don't want yours. But some say, I have mine, but I'll take yours too. Some people say, let the social worker come out. Don't have to. But really the nurse has to come out. The nurse's aide is usually welcomed. And then volunteers a lot of times are there. So questions, comments? Okay. So really, this is the, wow, look at that. Looking at Apple Macs is so cool. I was looking for the little red dot there. So the patient and the family are in the middle, and the nurses come out. The social workers that nowadays are called psychosocial specialists, don't ask me why. Chaplains are chaplains. Therapy specialists. We do physical therapy, occupational therapy, and speech therapy with palliative intent, which means to help people become comfortable, you know. Sometimes this is a little different. A speech therapist might come out to see if somebody can, how well they can swallow. You know, some people are receiving tube feeding and want to stop. Well, we'll have a speech therapist do a swallow evaluation, you know. Nurses' aides, volunteers, bereavement specialists, physician, our medical staff, we have physicians and ARNPs, master's level nurses. Then the patient care administrator, I don't know what that is. Probably the boss or somebody, but it's an extra to get that off there. I don't know, maybe it's a new thing we have. Good. Anyway, so that's the services. Now, Medicare provides, and we do because we're Medicare certified, and probably 95 to 98% of the hospices in the country. I think there's probably about 4,000 hospices in the country. Florida's a little bit different. In our state, we have what's called Certificate of Need. That's why there's only 4 hospices in this Jacksonville area. I moved here from Sarasota. I worked for a large hospice there for about 6 years. We were the only one there, so you had no choice. But ACA, our state agency, has this formula that if hospices do a certain amount of patient care, they don't allow others to move in. You know, I personally believe that you should have about 3 or 4 in a service area because competition keeps us on our feet, you know. Well, when I was in Houston, greater Houston, Harris County, we had 85 to 100 hospices there. That is too much. There are probably more hospices than Starbucks in Houston. You know? And the reason it's too much is hospices are paid by Medicare on a per diem rate. We get a certain amount per patient per day. And all hospices in the area get the same. So a lot of small hospices have a lot less cash flow. So you don't see beautiful care centers in Texas like we have here. Because we are larger, we have the funds, and we can build the care centers that people can use. And for other reasons too. But I think 85 is too many. So we use our care centers for short-term inpatient care. And that's, again, if the patient or the person who's sick needs symptoms controlled, if they start to get anxious, whatever, we can move them there. And we take care of transporting. We don't say, you move them in your car. But we'll have a non-emergency medical transport, usually an ambulance come out, but no lights and sirens, and move them into the care center. But first, the nurse will come out to the house and look at the medications and try all that we can do to keep the person there. Sometimes it's just adjusting medications. But we move them to the care center. And the care centers are really nice facilities. We have something called crisis intervention care or short-term care. If the person for some reason just says, no, I want to stay here, no care center, we can send out then nurses and other specialists by the shift. You know, otherwise, people receive a visit and the nurse or the other person leaves. It's intermittent care. We don't move into the house. But in this case, we would for a minimum of 8 hours, and it could be for a couple of days. My mother-in-law was on hospice service in our house in Houston, and we had crisis care for about 14 days, where we had nurses around the clock. She was in our bedroom, we were sleeping in that bedroom, then another room. But that is really rare that it would be 14 days. I don't know why that happened. I think they kept thinking she wasn't going to need it, so it didn't move her. And in Houston, being such a large city, the inpatient center was about 27 miles from the house, and I knew to go back and forth, and with our newly adopted son, it would not be a great situation. So I think that's why the hospice did that. So inpatient care, we also do that at hospitals. If we admit somebody in a hospital, sometimes we can admit them to our service in that hospital with the idea of getting them ready to go home. Maybe they need a day to get some equipment in the house, maybe to make sure symptoms are really controlled, then they can go home. So I think every hospital in this area we can use. Now, if somebody is really close to a hospital and wants to go there at night, we can do that. We prefer our care center because it's our staff, our medications, and real specialization there. And then short-term respite care. This is if the family needs a break. we can move the sick person into a care center for up to 5 days in one of those benefit periods, remember 90, 90, 60, 60. We can move into a care center, and the family can just get some sleep, go out of town, go to the wedding, clean the house, see movies, whatever they want. But we can do that for the family. Not many families take advantage of that. I think they just would rather be with that person, but it's certainly available. That's one of the good things of this Medicare benefit. So, any questions so far? Yes, sir.
What percentage of Medicare expenses go to those 4,000 hospice organizations?
What percentage that Medicare pays every year goes to those 4,000?
What percentage of the total Medicare expenses?
I don't know that. That's a good question. I read it a while ago. I don't remember it. It's a lot of Medicare money goes to the last year or so of life. And even though we're 6 months or less, the average hospice stay is less than that because people wait and wait. A lot more money, I think, goes to fetal care at the end of life, pre-hospice. I'll find out and I will let Dan know and he can let you know what percent. I think that's a good question. I should know. Let me tell you what hospice gets paid. It's not a secret. We get about $160 a patient a day. Okay. So if you're sitting there saying, well, they have a lot of patients, that's a lot of money. The way I look at it, if you ever had to go to like Walgreens or CVS and write a check for a prescription with no insurance coverage, $160 doesn't go real far, you know, because what we provide is all of the staff that I mentioned, the medications for the hospice diagnosis. Now, if somebody comes on with a certain disease, that or maybe all diseases they have might be part of the hospice diagnosis, but any symptom related to the hospice diagnosis, we provide the medications for that. Medical equipment, beds, walkers, commodes, oxygen, then any kind of supplies are covered too. Then all of the professional staff. You know, so that covers everything. The only thing it doesn't cover is the doctor visit, but we bill Medicare separately for that. You never receive a bill. So we get about 150 or 60 a day. A lot goes into that. But, okay. Some of the things that we do are a little different than other hospices. We have a program called We Honor Veterans, and it's part of the National Hospice Organization, and I think the VA. And we have special training for our staff to serve vets at the end of life, especially people who've seen combat. Maybe other issues come up at the end, so our staff is trained to work with those issues. But one of the really special things we do for our hospice patients is we have a pinning ceremony. There's a hospice pin that we've had designed with our name on it. And when persons admitted to hospice, they're asked if they're a veteran. If the answer is yes, we ask, may we recognize you for your service? And what we do now, it's a little bit different. When I started working here, the hospice nurse or social worker would recognize the vet who's the person with the pin. But we're doing this in Sarasota, and I think it's a lot more meaningful. We have about 85 volunteers now, all throughout Greater, Duval, and these counties at this point, not the other 11, volunteers who are also veterans. So these are the men and women who go out and recognize the patient who's a veteran. And so they'll go to the home. I get choked up every time I talk about this. It's so meaningful. They go to the home, to the facility, and if they can still fit in the uniform, they wear it, and if not, they don't. And they go out and they know the branch of the service, and we have a beautiful certificate with the name of the branch of the service, the veteran's name and rank. And they go out, and there's a little ceremony that we have, award them with the pin, the certificate, salute, and thank them. Very brief, but so meaningful. My good friend in Sarasota, his dad ended up coming on our hospice service and ended up spending his last days in a care center behind our administrative building here in Sarasota. And Dad was in the Army quite a while ago, and they honored him. And Dad hadn't moved for a couple days, but when the veteran volunteers saluted him, Dad saluted. And it was the last movement Dad ever made. And that stays with the family. You know? So it's so meaningful. We extended that. We do pinning ceremonies for non-hospice patients. We did one a couple months ago. I know you know Tula Wooten and I went out to the Vietnam Vets of America Duval chapter. We'll do it here too. And we honored about 45 Vietnam vets. It was at the anniversary, the 50th anniversary. We brought them dinner from their favorite restaurant. We had about 4 or 5 of our volunteer vets. We pinned 3 women and the rest men, I think, there. And it was a great evening. It was just so moving, so moving. And what really got me, when Tula and I were in the parking lot, she retired, she's not working with us anymore. We were standing there talking, just feeling good about the whole thing. One of our volunteers, he had been in the Navy, got out, he's going to nursing school and volunteering in our Hadlow Center on the weekends and doing this. He was driving out of the parking lot, stopped his car, backed up, put his window down and said, "Thank you for allowing me to do this." You know? And that's the sense that we get with taking care of vets, you know, and not vets too, of course, but vets, right? So that's what we're doing. We're also certified by the National Institute for Jewish Hospice, which means that we go to training every year and we have to follow certain rules and know about different types of Judaism and respect people with different, who are members of the different parts of Judaism. We do that well. We have chaplain service. To me, a chaplain is somebody who provides spiritual support to anybody of any faith system, any belief system, or none. You know, and you shouldn't really know that chaplain who ordained that chaplain, which church. One of our chaplains is a rabbi, others are Baptist, had a Catholic priest, but they're there to minister to anybody with any belief system. Okay. Is that a sign?
You may have to walk around and do
Yeah,
it
okay,
manually,
good.
Jim. Maybe you're at
Did I talk too long?
the.
Tell me there's an update.
There we go.
In our care centers, we have service line flags, and when a veteran comes into one of our care centers, we bring a flag and put it outside of the room that the vet is in. And that's the pin that we use there. Good. We have a program called Peds Care. We take care of kids. Not all of the kids are terminally ill. Only 6 or 8 are. But we have about 150 children on our service who are chronically ill. So it's a non-hospice program that we have, and we provide visits to the homes, support to the families, a lot of Easter time, Christmas time, special events, gifts. I think we just had one at the ice hockey game. One of the things, one of the kids did something special there. I don't follow ice hockey, so don't ask me what it was. So we do a lot for children that way, mostly chronically ill kids. We have two times a year, we have a camp called Camp Healing Powers. Actually, it's this coming weekend, and it's at Marywood Retreat Center, which is fairly close to here. We have probably 25, 30 kids attend. Our counselors are there, a lot of volunteers, a lot of fun activities, but we help kids who experience grief due to a death. And it's free to anybody who attends, and it's for any child up to age 17, starting at age 7. The reason it's called Camp Healing Powers, the Powers family daughter was on our service quite a few years ago, and we provided care to them, and they wanted to fund this camp. So ever since then, to this day and in the indefinite future, it's free to anybody because the Powers family underwrites the camp, which is really, I think, a nice thing. And that's an actual picture. It looks like one of those stock photos you buy online, but that's an actual picture of the kids. And they have a really good time, and they really bond, because it might be the first time anybody's talking to the youngster about what are they feeling, who did they lose, because usually we try to talk kids out of their grief feelings, and that doesn't work, because they wait. There's some booklets in the back, this very booklet. We started Advanced Care Planning, Honoring Choices Florida, a number of years ago, and started it as an effort with all the hospitals in town. There wasn't one document. We work with the legal departments of all the hospitals. So we have this document, it's an advanced care plan. What do you want? What do you not want? When you can't make decisions for yourself, not necessarily facing the end of life, but the decisions. And it works well. We do a presentation, an hour and a half, what is an advanced care plan. Then we have hundreds of trained facilitators who will sit down with people and finish their advanced care document. And the training is quite substantial. They can really answer the questions. Were you going to say something, Dan, about this? No, put your mic down.
Yeah, no, I
We're actually going to have a session that will focus on nothing but advanced care planning. That's coming up, I think, next month.
Yeah.
So, just so you know.
And you will have the expert here, Jamie Bowler, who coordinates this. And so far, there's not a question that she can't answer and have the right answer to with advanced care planning. So we're talking about how is hospice paid for. Medicare, Medicaid, private insurance. Because we are not-for-profit, nobody's ever turned away. Everybody receives the same care. If we have a patient on service who is not funded and doesn't have insurance, the field staff really doesn't even know that. You know, we don't say, well, this is a non-funded patient, don't do this, or just do this. Everybody receives the same care, and nobody in the field really knows. Not that we try to hide it, but it's not an issue. It's not an issue. Where do we go? Wherever the person calls home. Back in Houston, we took care of a couple of guys in homeless shelters. So wherever the person is or wants to be, we try to be there as well and keep them there. Sometimes, you know, in my years, we've been with people maybe way out in the woods in a mobile home that's not safe, and there's gas lines and oxygen and smoking going on. So we would have to say, we can't do this. And it really gets to be an ethical question. Do you tell somebody they can't smoke in their own house? What, to blow themselves up, you know? So sometimes we'll go to the ethics committee and we might say, we can't safely provide services for you here. And we might call Adult Protective Services in that case, just to make sure that things, not to turn anybody in, but just to make sure they're cared for. I served on quite a few hospice ethics committees. One time, it was a situation that happened in another state, but it brought it to us as a learning opportunity. Said that very thing. What if somebody is smoking and they're on service and they're facing the end of life? You know, should we make them stop smoking? So a long discussion, and they threw another one in. What if they're in a community living situation, say here, and somebody in the next room is smoking and they have oxygen going? Then is it different than if they were living by themselves way out in the woods? I think it probably is, because more people are involved there, so that could harm more people. So interesting things we look at. So area, and we mentioned all of these. So these are our care centers where they are around the area. You don't have to memorize these. But if you ever want to visit one, let us know. This is the McGraw Center that is at Mayo, right? You know, here. Where's this one? This is one of our care centers. Yeah, it looks like Sunbeam there. This is what one of the rooms looks like. Families can stay 24/7. You know, pets are invited. Horses, small horses have been known to show up with, you know, reservation appointments. But dogs, cats, I mean, they're invited, you know, because they're part of the family. I remember back in Houston, somebody was in a hospital and they wanted a dog to visit, and somehow they had to sneak this thing in, and they were trying to see, can we get a first floor room to bring it in the window? But we said, bring the dog in the front door, you know. St. Vincent's, Riverside, this is the family room there. You know, our volunteers, we have 900, 1,000 volunteers, and they do everything. Somebody says, what does hospice volunteer do? It's anything. Come out and do things like I'm doing, work in the office, visit patients and families. We're using people now to help with our bereavement support groups, make phone calls, just about anything that people can do for a larger organization. I'm not recruiting your volunteers from here.
Watch it.
I'm watching you watch me. Okay. We have ambassadors. These are people who are a little bit more trained, and they'll go out and work with health fairs, because we bring our banners out a lot of places and do a lot of things there. And really is a staff extender. I really feel like community hospice is part of the fabric of the community. You know, I've worked with other smaller hospices, and they're just there, you know, calling on hospitals, getting referrals, but we do a lot more than that. You know, we do things like this. We have advanced care planning talks, part of health fairs. Our bereavement services are available for 13 months after the death to anybody in the family and to the community as well. We do not provide one-to-one grief counseling to families from a community who didn't use hospice, but we have bereavement support groups all over the place. Some are ongoing, some are 6 or 8 weeks. We have a lot of different workshops. Sometimes a workshop is the best thing for somebody just to understand about the grief they're going through. We started, we have a cute name that I can't remember, but walking groups at the Hadlow campus now. Twice a month, a group of bereaved people, somebody had a death in the family, getting together, just walking around with each other there. Beautiful little grounds, trees, squirrels. And for me, just sometimes just being with another person going through the same thing is more help than anything else. Am I going backwards? Yes, I am.
If you're a patient in hospice, are you allowed to have your little dog there?
Mm-hmm. Yeah, dogs in the care center? Yes.
Oh,
Yeah, yeah. You can bring your dog with you if you end up in a care center, certainly. Sure. Now, I would say a dog like that one we probably have to talk about, all right? But my 9.5-pound poodle Leonard would be welcome, and that's not just because I work there, I think it's the size. We had, I think the last picture is there, here, and then back in Texas, of course, somebody had miniature horses visiting our care center. And not just because they belonged to a patient, but it was just somebody had miniature horses, and they thought people liked them. But they were wearing, you ever go to New York City and the horse-drawn carriages, they have that catch bag on the back? These little horses had a catch bag on the back. I guess that was a clinical thing. I'm not going to answer how to make a gift that's in there. And anybody can call hospice and say, can you come out and talk to us about this? We don't know. We can have the nurse come sit down with you and go over everything, or another person too. So our website, yeah, there it is. This is a real live horse, full size. One of our patients wanted to come out and have his horse visit him, so we arranged for it. You know? And to me, when I hear things like this is what hospice care is. There was just something in the newspaper about 3 weeks ago. We had a patient out in what we call the New Territory, Palatka, that area. A woman on service, came from a very financially poor family and was raising 2 kids on her own, and she went back and finished her 2-year degree at the community college. While she was on hospice service, she had a graduation, and the kids were there proud of mom, and she wanted to show them and set an example. The hospice nurse was there at the graduation. It was in the newspaper. I think it made the television news. When I see that, I say to people, this is what hospice is. It's really trying to live fully, focus, have conversations, you know, things that we maybe not said, say, you know. There's a book that a hospice physician, Ira Byock, wrote, and he talks about it's time to say, I love you, thank you, I forgive you, and other kinds of ways of saying goodbye. And that's what hospice is about. So, questions, comments?
If you have a question, let me bring the microphone to you, otherwise it won't get caught on the record here. So if you have any questions, now's the time. While you're thinking about that, I'm going to ask Jim, what are the main reasons you've seen where people don't call hospice when they should?
What are the main reasons people don't call hospice when they should or could? Death is a real difficult thing to acknowledge. To me, that's the biggest thing. We want to fight this, you know. There's been some articles online lately that I'm reading about, we say that we didn't beat the cancer, you know, but it's not a fight that way. It's happening all around us and to all of us. Sometimes people won't come on hospice service because they don't want their family to think that they're going to stop, you know. So many reasons, you know, many denial. Yeah.
What percentage of your funds are donated in wills and after the person died?
I'm going to have to get that answer too. We do have that, what percentage of the funds are left to us afterwards. I don't know. A small percent, but it's significant in funds because we are large and there's good cash flow. I know that we have probably 4 or 5% of our budget is donated to us. It's not earned through Medicare or other insurances, and we don't use that for patient care. We use it for education, for community support, for bereavement support for the community, the outreaches and things like that. But we don't ask patients to leave us anything in their will either. You know, that's a good question.
You also have this little notes thing. If there's anything on here you'd like to have Jim talk about.
Talk about the Sunbeam facilities, amenities like concerts and meals and things like that. I was blown away visiting somebody there and seeing what it was.
In a good way, blown away, right?
Wonderful.
Okay, good. Good. The food is good. I eat lunch there every once in a while. Cookie in my throat. We have a really meaningful holiday concert at Christmas time. There's a harpist that's in there a lot. There's somebody playing the piano in the lobby, and you can hear the music throughout. It's just beautiful there. It's very, very peaceful. Thank you.
And I know that when one of my male friends was in hospice, we asked him if some of us could go in there and sing, because he loved singing. And so we did a whole little concert in there for him.
That's great. Yeah. And if you have a friend in one of our facilities or care centers, want to do something special, like go in and sing, come on, just let us know. And if you want to sing in some other rooms, we can arrange
We've
that.
got a great grand piano.
But, yeah.
I do have a question. What is the connection between your agency and Haven Hospice?
The only connection between Community Hospice and Haven Hospice is that we're both hospices, both Medicare certified. There's no business connection, no community caring connection.
But do you work together on certain kinds of situations, or?
No.
No.
Do we work together? You know, we might get patients who were their patients coming to us and vice versa, but they would stop here and we would pick up there. It'd be like saying, what's the Atria and a Brookdale facility, both doing the same things, but there's no real connection there. You know, some of the staff come work for us, and I guess some of our staff will even work for them. But they're two independent, large, not-for-profit hospices. They're Gainesville-based, we're Jacksonville, working together. Their office is close to our Sunbeam Road. I pass it every day coming in on Phillips from Nocatee. But no, I've not even been in their office.
There are hospices that are for-profit as well as non-profit.
Yes.
And community hospices are non-profit.
Right.
And I also wanted to mention that at Christmas time, they have a celebration for the people that have died, and they have names hanging from Christmas trees. And the families are invited to that so that they can interact with other families who have lost and have grieved.
Yeah, that's a beautiful ceremony. People there do make a donation, and the deceased person's name is put on a ribbon that's on a big Christmas tree, and our chaplains carol, and other people come in, and there's great food, and it's a time just to remember all the people that we've cared for. As I said, there are 4 hospices in this area. 2 are for-profit, 2 are not-for-profit.
Which 2 are for-profit?
For-profit are Vitas and Heartland. Heartland is based out of Toledo, Ohio, and they do home health, they do rehab, and they have skilled nursing facilities. Vitas is the largest hospice in the United States. It's based in Miami. You can buy ChemEd stock. I mean, I track their stock. If I had bought it a while ago, I'd probably be retiring sooner. It's really well. I can't buy stock in community hospice, just feel good. But ChemEd is their parent corporation. They also happen to own Roto-Rooter. So Vitas and Roto-Rooter have a connection that way. Go figure. Yes, sir.
Jim, is it a Medicare or is it community hospice that you cannot try a curative process, to go on chemo or to go on radiation? Somebody restricts that and asks you, or you have to step out of the hospice program then?
Good question, and it's kind of a tricky way to understand this. In the earlier days of hospice, say 15 years ago, hospices just used medications like long-acting morphine, acetaminophen, things like that. And they would never do chemotherapy, never do x-ray therapy, because we're paid by the day. We can do any treatment we want as long as it's palliative in nature, treating the symptoms, aggressively treating the symptoms. So we do work with oncology groups, and our patients receive chemotherapy for symptom control the size of the tumor. Our patients sometimes go in the hospital for some kind of surgeries, placement of tubes. So there's really nothing that we can't do if it's palliative and if it has palliative intent. The same chemotherapy could be used for cure and palliation. As long as we can clearly understand and define that it's palliative, we do it. We have a physician's advisory board that I helped get going with Dr. Sanchez, our chief medical officer. And one of the doctors there said to me, I have a number of patients I would refer to you, except you're going to take them off all the great medicines I put them on. It took him a long time to get the medicines just right. Give them, he's a pulmonologist, a prednisone pill, and that'll be it. I have them on this, and I said, Dr. Sanchez, would you answer this? She said, there is nothing to that doctor that you use that we would not use. She said, sometimes these medicines are thousands of dollars for an inhaler. And she said, I want to tell you, I went to our chief operating officer and I said to him, you said don't let money get in the way. I'm going to test that. I need this medication. I think it was close to $20,000 to buy what we needed. He said, go ahead. Yeah. So we don't let money stand in the way. So any treatment as long as it's palliative. But in the old days, hospice, it would lead people to think that we can only do certain things because of that. Good question. Yes, sir. Here comes right here. Oh. What was his name? He was Phil Donahue. Here comes Phil Donahue.
Okay. My wife is here in our health center, and as far as I'm concerned, she's in good health.
Mm-hmm.
In other words, she's bedridden, can't walk, but yet she does okay.
Mm-hmm.
But the other day, I had someone suggest that we call hospice
Mm-hmm.
to work with her. Now, what would you say? They didn't know what they were talking about?
No, I wouldn't say that. If it was just you and me, I might. No, I wouldn't. No. I think, why not let hospice come in? It would be extra service. You know, maybe they're thinking we need more eyes on your wife to see. Maybe they're concerned that maybe she's declining and hospice could help. They don't know, and there's nobody in this room who could say somebody's within 6 months. Remember, it's two physicians. You know, I was at a talk the other day, and somebody said the same thing, that somebody in a rehab center said, call hospice, you know. Actually, it was at a church, and it was a 93-year-old woman that said she was in rehab, and they said, call hospice on her, and she said, not me, you know. I said, okay, you know. But I think, you know, somebody says that maybe there's a reason, maybe they just want to be sure, and it's, you know, maybe save, if you want to look at finances, more medications come in you don't have to pay for them, maybe more equipment and supplies, maybe she's going to need a walker or a physical therapy. Why not? Yeah. I think what Dan said before, it's the H word that scares us. You know, it's that hospice word that scares us. You know, and I half jokingly say we started saying palliative a couple of years ago because it's a bigger word, because people think hospice is a few days left. But it's months to years, you know, and it helps, and people go off. So we can look at it as sort of a support for a while, and if we don't need it, we're gone.
Jim, a number of folks here are caregivers.
Right.
And the question I would ask is, if a person qualifies for hospice or palliative care, what can you do for the caregiver? Where does the caregiver come in?
Good question. You know, think about our services. We have the social workers, the nurses, the volunteers. Those, and also the chaplain, can provide services for the caregivers. Sometimes to sit down and say, tell me what it's like. And sometimes the caregiver, we're going to feel guilty. I can't take this anymore. You know, I'm going 24/7. I remember when my mother-in-law was on hospice, and before that in an assisted living and skilled nursing. Every time the phone would ring, my wife would jump. You know, I would too. I learned to jump from it because we're thinking, is it the nurse calling us? You know, it was so stressful. But being able to sit down and talk about that, we can provide that support to caregivers. Education, information about maybe caregiving events. We're going to be doing, last year we did a number of caregiver workshops. We're going to be doing more. We're going to be doing one in St. Augustine, end of the month, way up in Nassau where I was this morning, and other places to get together with other caregivers to learn the skills of caregiving, which is basically self-care.
We're nearing the end of the session, so if you have a question, this is a good time. If it's something that is more personal, that you'd like to talk one-on-one with Jim or Marie or somebody else is here, Melissa?
Yeah, we have brochures and things.
We have brochures, but please feel free to.
And you know, I don't want to leave here, so I'm going to stick around. I'd rather be here
Any
than
other-
in the office, you know, where this is beautiful here.
Any other thoughts or questions before he takes off for Barbados or wherever?
That's Friday, Saturday. Good. Thank you for being here today. Thank you so much.